Video endoscopy with stroboscopy, also known as video stroboscopy or stroboscopy for short, is the most common method for visualizing the vocal fold vibration and is essential tool for voice assessment. It is used for evaluating the pliability of the vocal fold mucosa, which is an indication of health and function of the mucosal tissue and deeper layers. This video stroboscopy first described by Ortal in 1895. The term stroboscopy comes from the Greek words whirling, to look at. So this concept first given by the Ortal in 1895. The stroboscopy Greek terms means whirling or to look at. During phonation, the vocal folds vibrate at high frequencies too rapidly to be perceived by naked eye. Stroboscopy is used to slow down the vibration in order to facilitate assessment. It uses flexible or rigid endoscope combined with microphone and a flashing strobe light. The microphone is placed next to the larynx and estimation of the fundamental frequency of voice is done with this combined endoscope with microphone. The mucosal wave cannot be seen due to relative speed of vibration of vocal folds, usually 100 cycles per second, compared with the ability of retina to process individual images 5 images per second. So, slow down this process, we require video laryngostroboscopy to properly assess the phonation as well as vibratory pattern of the mucosal fold and mucosal pathologies. There are some drawbacks to stroboscopy due to sampling technique required, as only periodic vocal fold movements from successive glottic cycle are captured. Aperiodicity or fluctuating vocal fold movements cannot be traced. Another situation in which stroboscopy perform poorly is diplophonia, a condition that produces two separate pitches simultaneously, thereby disrupting the stroboscope microphone's fundamental frequency estimate and causing irregular flashing and inconsistent set of images. Stroboscopy may also not accurately represent the movements of a single glottal cycle if there is irregularity from cycle to cycle. In these cases, video chymography, high speed single line video scanning, or you can say high speed video laryngoscopy may be more effective in these three situations. First is it cannot be accurately assess the aperiodicity. Second is it cannot assess the situation in diplophonia. Third one, it cannot assess the single glottal cycle properly. So these are the three drawbacks which can properly assess by the video chymography or high speed video laryngoscopy. Assessment by this. First is glottal closure pattern. You can see anterior and posterior gap, hourglass or spindle shaped opening, irregular or regularity of vocal fold, and closed phase pattern. Second, you can assess the mucosal wave changes with symmetry, periodicity, and degree of changes. You can assess the description of lesion, color, shape, multiple or single, and surface of the lesion. You can assess the vocal fold opening pattern like range of full or reduced, normal, or presence of spasm or tremor during the vocal fold opening and closing pattern. You can assess the supraglottic appearance like false chords, constriction, anteroposterior constriction, and some prominence lesion in the supraglottic. You can assess the symmetry of arytenoid like sagittal, coronal, or axial plane. So you can assess this situation by this video laryngoscopy. So 10 common thing you can assess with this video stroboscope. First is amplitude, the lateral extent of vocal fold displacement during the opening phase. Second is mucosal wave, pattern of vocal fold tissue deformation. Third one is vibratory behavior, the presence of any non-vibrating portion of vocal fold. Fourth one is supraglottic activity, extent of laryngeal compression. Fifth one is age, the rating of smoothness, roughness, straightness, irregularities of vocal fold ages. Sixth one is vertical level, on plane versus plane vocal fold contact during the closing phase. Seventh one is phase closure, the rating of open and closed phase duration. Eighth one is phase symmetry, rating the percentage of the time with symmetry between the left and right vibratory phase. Ninth one is regular tip, rating the percentage of time with regular vibration. Tenth one is glottal closure, describing the shape of the glottic closure. It means video stroboscopy is currently the gold standard for laryngeal imaging. Its cost effectiveness, ease of use, and real time audio and visual feedback make video stroboscopy an effective means of diagnosing the vocal fold disorders. In addition to its part in evaluating the voice disorder, video stroboscopy plays a role in oncological surveillance. A reduction or absence of mucosal wave suggests abnormal structural health and pliability of vocal cord, which may indicate dysplasia, early glottic carcinoma, scarring, hyperkeratosis, or inflammation. Video stroboscopy can also be used to assess perioperative functional status, document the effectiveness of voice therapies, and monitoring surgical outcomes. So you can see like some lesion, vocal nodule, cyst, and vocal polyp. The pattern of symmetry, periodicity, amplitude, mucosal web pattern. So this is very effective and gold standard for laryngeal imaging.